Cardiovascular health. My name is Brandon Garrett, as most of you know, I guess. I work as the CEO of the National Minority Quality Forum. Before everyone joined us, we're having a nice little HBCU conversation. We have Howard, Hampton, Alabama State, Clark, uh, the Dillard, all represented on the call. So I had to go ahead and put on my Xavier shirt just for, you may as well. But I'm going to start the program off by introduce my next door congresswoman. I'm in Florida, but just a little bit north of me, Congressman Sheila Shafirlis McCormick. I'm sure I butchered that. I don't speak Haitian Creole, but I'm sure she's going to pronounce it better. She is uh, been in Congress for the last couple of years. I'm sort of ad-libbing a bit. They gave me a bio, but I met her years ago with a good friend of mine from law school, Gabrielle Charles Sanders, and we spoke then. And now she's doing great work on the Foreign Affairs Committee and the Veterans Affairs Committee, where she's a subcommittee chair. Additionally, she's an attorney by training. So after Howard, she went to law school, but then she also has a lot of a background in the healthcare space. And so not only is this something that, she's just helping us out and supporting, but she also is very familiar with the healthcare world. So without further ado, I'm just going to go ahead and turn it over to the Congresswoman and let her bring some remarks.
Well, good afternoon, and thank you so much for that great introduction. And everybody butchers my name, so you did one of the better jobs. I'm Congresswoman Sheila Sherfilis McCormick, and I want to start off by thanking the National Minority Equality Forum for the nonstop work they're doing to move the needle forward in health equality. Every single American deserves access to quality care. I also want to recognize the phenomenal panelists. Your commitment in providing cardiovascular health is making a real difference in saving lives. As you mentioned earlier, before I came to Congress, I was actually a healthcare executive. Once I left law school, I went into healthcare regulations and worked my way up. And one of the things I saw personally was how the Black community is being inundated with all types of diseases and all types of issues. Mental health stresses us out, and we just don't have access. But the one thing I saw at the end of the day was cardiovascular disease. If you started out with high blood pressure, if you started out with diabetes, if you started off with high cholesterol, at the end it was cardiovascular disease that ended up taking you out. And the most harmful thing about this was that I literally saw our elders, our family members, the ones who we needed to rely on to keep our families together, passing, parents who were passing. I tell people all the time, I go to the most funerals in my district of Black men who are between the age of 40 and 50, who did not know they had high blood pressure, who did not know they had high cholesterol, who have had strokes. And if we continue in this trajectory, we will not have Black families or strong families. And so that's really what drove my agenda to ensuring that we have access to equitable treatment, that we are made aware and educated on what actually causes cardiovascular disease, and make sure that we're constantly moving legislation forward that helps us deal with it. And so one of the things that I introduced when I came into Congress was to really make sure we had a bipartisan resolution looking at cardiovascular disease, but recognizing cholesterol and high cholesterol and educating ourselves for the month of September. The next bill that I moved forward was AEDs and making sure our children who play sports, who are having these cardiovascular attacks on the fields, have access to life-saving treatments and tools, which right now it seems like it's a silent killer for most of our kids who play sports. But it's going to take more than just us having legislation. It really is going to take these forums so we can start talking and teaching our families on how to make sure they're getting the healthcare they need, how to make sure they're using it, and how to make sure that they're spotting the issues that they're finding in their lives. And so I'm so proud to be on this conversation today and to introduce and start it off, because this is how we change the trajectory of our Black community and our Black families. At the end of the day, our generational work, as I call it, is to ensure that we have not just elders and parents and children in our families, but we have thriving, healthy families. And for us to get there, it's going to take the work that we're doing today. So thank you so much for having me. And we look forward to working with this organization and other organizations to make sure we're not only moving legislation, but we're moving the entire Black community forward in the most healthiest fashion. Thank you for having me.
Thanks so much, Congressman. It's great to have leaders like you in office. Not only do you actually have the experience in the healthcare space, right? So we don't, it's just not something, it's something that you're very familiar with. And it seems like you've had this commitment for some time. So we really appreciate you joining us today and working with us. So thanks so much.
Thank you for having me.
And we all know how busy you are. So And so before I turn it over to Dr. Asante, I just want to remind everybody of a couple of things. One, if you have a question that you'd like our panelists to answer, please, if you look at the bottom of your screen, there's a question and answer box. Please place that in that box. And within the last 15 minutes, Dr. Asante and team will get to it. And then if you have some chat or you want to make everyone on the call, the conversation aware of something, please put it in the webinar chat feature. Finally, my last announcement, as you know, we're celebrating our, I believe, 23rd or 24th National Annual Summit on Health Disparities, April 29th and 30th in Washington, D.C. We'll put a link to information about that in the chat as well. Now, to lead our conversation, I'm going to turn it over to Alabama State's own, keeping the HBCU conversation going. Dr. Andrew Asante is a pharmacist with Amgen. He's did some work at the University of Florida and did some clinical training somewhere else, but the most important is at Alabama State to be. So I will go ahead and turn it over to Dr. Asante to lead our conversation.
Hey, thank you, Brandon. Alabama State University, go Hornets. I think you nailed it right on the head. I'm really happy to be here, everyone. My name is Andrew Asante. I'm a senior manager, external medical engagements at Amgen. I also work as a global health equity lead for the Amgen Black Employee Network. Really excited to be here. But first, I really want to thank Honorable Congresswoman Shafilas McCormick for such a great remarks in introduction. I really feel like we could round up after what she said. And also, I really want to say thank you to our distinguished guests for making it here, because we have an important discussion and we have the right people. And I do believe that this is the right time for that discussion. Before we delve into the discussion, I really wanted to set the stage for us. What are the facts about, cardiovascular disease in America? Every 40 seconds, someone experiences a heart attack or stroke. And that is why February is the designated Heart Month, to raise awareness for cardiovascular disease. Specifically, when you look at communities of color, especially Black Americans, they have higher rates of cardiovascular disease and are disproportionately affected by cardiovascular factors such as hypertension and obesity. For example, while Black American adults are 30% more likely to have high blood pressure, they are also less likely to have this blood pressure under control when compared to non-Hispanic white adults. Also, by the year 2060, projected rates of cardiovascular disease is expected to increase significantly, disproportionately affecting communities of color. Now, these numbers alone should tell us that cardiovascular disease is a public health crisis and should not be ignored. Yet, we continue to see persistent barriers that prevent Black Americans from getting the care they need. This includes access to screening services for LDL or bad cholesterol, one of the most easily modifiable risk factors. During today's conversation, we will hear from people with expertise and experience related to heart health, as well as ways we can help support actionable policy solutions to close the gap for cardiovascular disease for Black Americans. We'll start off with brief introductions. I already told our esteemed guests today that if I was actually supposed to look at the work they have done and the work they continue to do, I would need about 30 minutes to go through the bios of everyone. And so this is a very brief bio for everyone. I'll start first with Karen Jones. So Karen Jones is the president and CEO of the National Caucus and Center on Black Aging, NCBA, and NCBA Housing Management and Development Corporation. During its 50-year history, NCBA has been the only national organization devoted solely to providing effective leadership in making minority participation in aging services a national issue and priority. Prior to becoming NCBA CEO, Karen was Executive Director of Federal Relations with SBC Telecommunications, now ATT, in addition to many additional previous roles. We also have Tara Robinson. Tara is the CEO and co-founder of the Black Heart Association, an organization dedicated to promoting heart health and equity. I really think, Tara is everybody's hero. Beyond her role as a leader, Tara is a remarkable individual who has triumphed over adversity, having survived 3 heart attacks. Her personal journey fuels her passion for advocating for better heart health awareness, care, especially in Black communities. And finally, but not the least, we have Dr. Warren Jones. Dr. Jones has over 30 years of experience in healthcare. He founded and established the Mississippi Institute for Improvement of Geographic Minority Health and Health Disparities at the University of Mississippi Medical Center. Over the years of his career, Dr. Jones has been recognized for his pioneering efforts in the field of health, as well as a distinguished educator. I'm really excited to have you as an educator because we need some more education. Dr. Jones, I ended the bios or introductions with you, and I also want to start our question today with you as well. So we have, a lot of people on the call today, people from all walks of life. And my question for you is that, what is cardiovascular disease and how does LDL cholesterol or bad cholesterol relate to it?
Well, Dr. Asante, first of all, thank you very much for your kind introduction. And thank you to the National Minority Quality Forum for the invitation to participate today. I see my friend Tara on the screen, and I call her my gold nugget because a gold nugget is when someone faces death outside the hospital and is recaptured. And for her to experience that 3 times, she's my triple gold nugget. So when I go to Vegas, I'm going to pay for her to fly with me. But it's important for everyone to know that cardiovascular disease refers to several types of conditions of the heart. Specifically, the things that you're concerned about are how's the heart itself impacted and how are the blood vessels impacted, and the whole cardiovascular system. What a lot of people struggle with is when you talk about cardiovascular disease, you're not talking about just the heart. You're talking about delivery of blood throughout the entire body, to the kidneys, to the brain, to the lungs. So cardiovascular disease is really important to know about. If there are high levels of bad cholesterol in your blood, then deposits known as plaque may form. And these deposits form in the blood vessels and makes it harder for the blood to flow through. And the reason blood pressure is measuring how much pressure it takes for blood to flow through your blood vessels to get to your brain, your eyes, your heart, and other places. When they narrow that aperture, it makes it really critical to get the blood supply you need. And oftentimes, plaques break off in the bloodstream. And when the plaques break off, they can block off the blood vessel, and that's called an occlusive activity, and it can lead to a heart attack or a stroke, temporary blindness, or even kidney failure. One of the other things that's happening a lot more now, because of the number of old people like me, we talked about aging earlier, and I'm 75 now, so I fit the diagnosis, the definition of old people. Vascular dementia, people that seem normal otherwise, and if their blood pressure goes up too much, it may impact their ability to think and function. So it's one of the things that, as my colleague Karen Jones is going to talk about, we got to help our elderly people to know how to deal with that. But thank you for the chance to talk about that.
So, Dr. John, thanks for setting that foundation for us as we move on with the conversation. And Karen, I'd like to bring you in because, Dr. Jones brought it up, aging, right? So one of the things when I started was, how cardiovascular disease disproportionately affects Black communities. Can you give us a sense of the prevalence of cardiovascular disease in Black communities and also in the aging community as well?
Absolutely. And I also appreciate the opportunity to be on this esteemed panel. Let me just first say that in CBA, we focus on low-income seniors. And so that's why we know that that is the group that needs more attention to making sure that they have a quality lifespan, and that we give as much information to them to empower them so they can be advocates for themselves in terms of their health and all other issues. There's so many barriers that reach our people. And unfortunately, once you get older, you really have had to face many, many challenges. And that's where we also begin to see a lot of these health disparities as a result of not having access to quality health care for the majorities of their lives, particularly if you are low income or poor. You know, we have a higher burden of cardiovascular disease risk factors, hypertension and obesity. We're twice as likely as whites to die from cardiovascular disease. And similar, those stats mean that we get delayed diagnosis and then delayed effective treatment. And all of those are as a result, of course, and we've had many, many webinars on health disparities. All of those that affect us because of lack of access and not having the opportunity or the information to even be able to ask what it is. NCBA just hosted last month a webinar on heart valve disease, something that's never really talked about and our people aren't really aware of it. So we make sure that we get as much information out to our network to empower them and to advocate on their part. I can tell you, though, that for all African Americans, or seems like people of color, just access in terms of even working with our health plans, we find that there's a process that again, we find these disparaging and challenges that are in place. So we want to make sure that our people get as much information to understand. Just as Dr. Jones explained, it's not just about the heart. It's about all of the other things that we can do personally, but then also the questions to ask, the things that you can have access to make sure that the healthcare system works to work with you to make sure that you have as much in terms of quality healthcare.
And Dr. add one thing to that, please.
Yes.
A lot of people don't understand that a disease is not a disparity. When I give lectures to medical students and residents and doctors, I always ask, is diabetes a disparity? How many of you feel that way and the hands go up? And I ask about high blood pressure. And what they don't understand is no disease is a disparity. It's the system's response.
Right.
The burden of disease that constitutes the disparity. That's what came out of the Institute of Medicine study. And when you look at it, there's so many causes, as Ms. Jones just talked about, including the social drivers of health and the non-medical factors that influence health outcomes. I ran the state Medicaid program here in Mississippi. And when I retired from the military, I was the senior medical director for the worldwide program called TRICARE. And I can tell you that at every turn, I ran into barriers for minority patients getting the care they need, not necessarily in the military treatment system, but when we have to send them outside. So the barriers are real, and hopefully folks on this call can effect the change. So thanks for allowing me to add that.
No, so Karen, Dr. Jones, I'm hearing empowerment, I'm hearing access, I'm hearing education, and I love that addition of the difference between disease and disparity. So really, thank you for adding that as well. So Tara, most of us or some of us, we talk about cardiovascular disease, but for you, it's a little bit different. You have experienced it. And you have a personal journey that really actually transformed you from even just being a patient to an advocate. And can you share a little bit of that journey with us? And now in your current role as CEO of Black Heart Association.
Yes, thank you so much for having me. And I'm very excited, and I love listening to the other panelists share their thoughts. As I was listening, I thought about my journey from having my 3 heart attacks. I had one April 10th, April 11th, and April 12th. I ended up having a massive heart attack, going into sudden death, coming back here and realizing that there's this huge gap between how we receive information and care and screening, because I'm an insured individual, so I was bothered. And I'm someone who is always in touch with the healthcare system. So to have 3 heart attacks completely catch me off guard the way they did, I realized, for one, that the way the information is given to us is not received in the way that we clearly understand that it can happen to us. And so dying in this situation and not having blood pressure, cholesterol issues, or diabetic issues is a subject that we often don't talk about. So here I am now as the CEO of Black Heart Association. I'm in the field each and every weekend. And this month alone for Heart Month, we did over 29 events. It's 29 days. We did 29 events this month. So with that being said, what we're seeing is we don't talk about the correlation between bad LDL and stress in our community. When we talk about health disparities and all that, the systematic things that we experience as a community and its impacts on us, the lack of trust, the lack of access. So with Black Heart, we provide all that. We provide the trust. We provide the education. We provide the access. We know the numbers because we're screening them for their cholesterol and blood pressure and all glucose and all those things. And so we hear from the community a lot about, what they want care to look like.
Yes.
And it's personable. And so we've taken the relation piece out of care, and somehow we got to figure out how to put that back in. So when we talk about the impacts on us in the years to come, I would like to think that we're going to say that that's not true. Yeah. If Black Heart is out here in these streets, we're going to make sure that that number does not impact our family. So we're not having those funerals like the Congresswoman spoke of earlier.
No, Tara, thank you so much for sharing that. Sharing that 29 days, 29 events. It takes a lot of commitment and a very big why to be able to do that. And so, Dr. Jones, Tara said something that is really important. When you think about the physician-patient relationship, you talked about how information is shared, but how is that information perceived, right? So Dr. Jones, if I'm a patient, can you tell me more about LDL cholesterol? What information should I know as a patient in terms of testing and also treatment options?
Well, thank you very much again. And I just listened to my newfound friend Tara, and it just invigorates my heart. If you don't mind, I'll share with you that as a Black woman and as women in general, you're at increased risk of heart conditions that go undiagnosed until they get to a point of severe catastrophic impact. My daughter died at 47 years of age of congenital failure. And I'm a physician, and I'm a national speaker on heart disease. But when I talked to her about what she needed to talk to her doctors about, they were not very receptive. And 2 weeks after I told her she needed a pacer defibrillator and her doctor declined to do it, she was dead. So the point you make about communicating with their relationship is critically important. One of the things that as patients, we all need to know, we've learned about cholesterol, and we know that there's high HDL, high density lipoproteins, and LDLs. And everybody says, get your HDL up. Well, if your HDL gets up from exercise and other things, that doesn't necessarily get you out of the woods. If you don't pay attention to your LDL or your low density hypoprotein, and there's a specific category called C, that's low density lipoprotein C for cholesterol. That can be measured by a simple blood test and lipid panel. And it doesn't really take a whole lot. And the elevation in that level can really indicate whether you're at risk or not. Clinicians should do a very good job of addressing this with their patients, helping their patients to understand that you can play a role in improving your health by modifying your diet. When you're prescribed medication, taking it. Talk to your family members to help them to do the things that they need to do. But we also have got to educate patients on the course of their disease, the ways to make a difference, and their medications and why they should take it. And physicians have got to learn to talk to patients where they are and not talking to another doctor. One brief story, our family member complained for many years about a misery in her side. And I kept telling her, go see your doctor. And she would come back and say, the doctor says it's just a misery in my side. Well, I sent her to another doctor who's skilled at listening to patients. And that doctor saw her on a Thursday, had a CT on a Monday, and had surgery for cancer on that kidney, on on the following Monday. Okay, now that emphasizes the importance of finding doctors who will talk to you and other healthcare providers who will listen to you and talk to you in a way that you can understand how to be a player in your own health. And to me, that's going to be critical in making sure that we can bend this curve that stops. The Association of Black Cardiologists used to have a tagline. It said, children should know their grandparents. And how
Wow.
often grandparents dying too soon. Okay, we've got to change that. Okay, and I think discussions like this will make all the difference in the world. When you go to get that lipid panel, pay attention to the HDL, but also pay attention to that LDL-C and the impact it can have on your life.
And if I could add to that, if that's okay, Andrew, what to what the doctor's saying, what we're seeing out in the field is a lot of us are getting to the doctor. However, like the doctor said, the explanation between what LDL is, what HDL is, how triglycerides, and how all these things work together to affect our heart health. And so there's a miscommunication there. It's a huge gap. And it's concerning because we're looking at the My Health charts, and people don't know what their LDL is. The doctors are telling them you're okay, but what does okay look like? Is the LDL too close to 100? Should it be under 70 if you're a heart attack survivor? So that general statement of my total cholesterol is okay is not enough. So we have to make sure our community understand that that's not okay. We should expect 5-star service, just like we do at hotels and restaurants, from our doctor. And if we're not getting that, and to me, a clear indication that you're not getting that is that you don't understand what's in your chart. So if you come to the bus and we have to explain that, then you need to go see another doctor, because we have to slow down and make sure that we understand all the blood work that's being done, make sure we understand what's in our charts, and especially LDL is one of those things that we do not understand how it works, what it does, and how it impacts the heart. And doctors should be able to connect those dots for us, we would hope. So make sure you're getting 5-star service from your doctor, and if not, see another one.
So may I just say something to it? Because what we're finding is there's so much intimidation on patients when they go to their doctor. That's the person who's the educated, trained, knows all the answers. And we're just saying that no one knows you better than you. And if you're having a pain and they're just saying things like, well, that happens when you get older, or those are just things that just happen. I mean, those are the kinds of things we have tried to say, nope, you have the power, you have the information. And that's why forums like this are so important, and that we take them even beyond here to really explain to our people why they have to advocate for their own health and not take, particularly the one that I hate the most. Those are the things that happen to you when you get older, or that's just, part of the aging process. Doctors will say that to someone. And if they understand about cholesterol, if they understand about those things, then they'll know what questions to ask. And that's why we have to make sure they understand the difference between the two, and why both of them are important to know, so that when some doctor says it's okay, you're okay, okay is not the answer. So I appreciate you saying that, but we got to get past that intimidation of when they go to a doctor, that they feel like, wait a minute, you're here.
I'm sorry, it's called participating shared decision making.
Yeah.
Shared decision making. It means that I sit down with my patient, talk about what's going on, and reach a contract. This is how we can help you to get better. What do you think? Okay, that's the shared decision making. There are two things we got to have our people of color demand, or to participate in shared decision making and to have team-based care. Team-based care means you have people with expertise in areas that you need to learn how to take care of your total process. Because when you walk in, you're not just a blood pressure walking in, okay? You're not just a kidney disease walking in, you're a total patient. And if that clinician's office is not able to take care of it, then they need to have a colleague who can, and coordinate your care so that you can live longer. Not only add years to your life, but add life to your years.
Dr. Jones, Karen, Tara, I just feel like we could end it right now. I think that the message is clear, the call to action is clear, and I really love the shared decision-making component, but also the empowerment from us to be able to ask the right question, to demand five-star service. You know, I want to double click. I'm a little bit curious, Karen and Tara, if you could help me here. How can community organizations like, you know, NMQF, NCBA, and a Black Heart collaborate to kind of increase this awareness, increase screening, and kind of, especially in underserved populations?
Well, I'll go first, Tara, and then I know you'll come in with something brilliant. Well, NCBA, we enjoy and really work hard for partnerships, because we know that though our network is really geared towards, again, low income seniors, we know that if you're not low income, you still need some of this information. So partnerships are vital to us getting the word out to our communities, and again, educating them and making them aware of what's important. That's why I'm glad to be a part of this. I've got new people that I can relate, you know, I can call on. Next year, I'm telling you right now, Tara, I'm going to have you on with Heart Month, because you need to come on and talk about your experience, because people can relate to that. And personal stories always make people say, well, wait a minute, that happened to me. And so these are the things. So we learn from each other. And we've got, you know, we know the bias. We know the racism and the things that continue in the healthcare system. Our people may not still be aware that they're facing that. And so that's why they just take whatever treatment they get, what other explanations they get. It's up to us as a community to make sure that we're doing all we can. And we do that by partnering together, not going in silos, and making sure that we're getting that information. And again, empowering our people to be advocates for their own health.
Oh, I love that. Please don't get me hype on this call today. Yes, partnerships are so important. And I'm so, honored to be here and meet all of you, because I haven't been connected to any of you, so all of this is very important. I think, as someone who faced bias and racism in care, I always say the solution is right here in our own communities. We are solution-based at Black Heart. We don't have time to wait on anybody to make this change for us. And so as we venture to go national, we're based in Dallas, but we're getting another bus in Houston, then another bus in San Antonio, then Louisiana's next, so on up, Mississippi, here we come, So these are the things that we as a community can come together and solve. We don't have to struggle. We don't have to be the face of every disease out there. We just don't. And I think for us as a community, God gives one of us a vision, but he always tells us to go back and seek wisdom and seek our elders out that have walked this thing before us, to come back to give us advice and to educate us. So even though Black Heart is not about me personally, it's for everybody that has a loved one that's 6 feet and under, that cannot share their stories anymore. It's for a call that I get from a woman being dismissed from the hospital saying, hey, they dismissed me, and go to another hospital and I'm having a heart attack. So this is for all of us. We, to have funerals because of high blood pressure or cholesterol, something that is easily prevented, stops with us. The buck stops here. With all of our organizations being as large and wonderful and beautiful as they are, we come together, we say, hey, the solution is within us. Let's come to the table and solve it. And that's all about partnership and support and word of mouth. And that's how the bus moves. It's word of mouth. We don't have mass dollars in marketing. It's word of mouth. And that's how we come together and we solve our own problems. We're all of y'all HBCU grads, y'all geniuses. So we're using that to solve today's problems in our own communities.
Yeah, I just want to say, and let's just remember that if we wait on other people to solve our problems, we'll be where we are. And that's why we have the health disparities, the social health determinants, all of those things in place, because we may have spent too much time waiting on other people to solve our problems. We're going to have to solve our own problems, because we know that's not the direction that they're taking. So we have to be the leaders in this.
Well, so, Karen, Dr. Jones, Tara, I think that I'm hearing something about partnerships. I'm also hearing about how we can solve our own problems. So I'm going to start with you, Tara. What can be done to address administrative barriers?
What can be done?
What can be done to address administrative barriers?
Are you saying administrative barriers? Is that what you
Yes.
said? What can be done? I think it's one person at a time when we go into these systems of care. Instead of trying to move us along like we're in an assembly line and taking us so fast through this process, it's multifaceted. We have issues with insurance and even hearing from doctors and what they're facing concerning insurance. So I think from an administrative perspective, we're looking at what is the patient saying? We don't listen anymore. We listen to what is the saying in counseling? We don't listen to hear, we listen to speak or to interrupt, or we're not actually active listeners anymore. So I think we have to start there with actually listening to what the issues are. Why isn't 1 + 1 equaling 2 when it comes to this patient? How did I get here as a heart attack survivor?
Yeah.
And not knowing that I could have a heart attack. So I think starting there, like, we have to begin to listen, but it has to be the right people listening as well.
Yeah. Karen, Dr. Jones, anything to add to that?
Well, I'll just say that because one of the things that we do for NCBA here in Washington is we are advocates up on the Hill, trying to work with our policymakers in addressing this issue. Right now, there's the Safe Step Act, which gives a reasonable limit to step therapy, and ensures that, health plans provide better protocols and access to treatment. And that's a bicameral, bipartisan piece of legislation. So we're still taxpayers. And so I say that it's up to us to do all our work, but we're still taxpayers, and we should still require our policymakers to address our needs and address them so that they do impact and are effective for us for getting the kind of treatment we deserve.
Yes, no. Go ahead, Mr. Jones.
Got to emphasize to our colleagues that are on this program with us that what we're talking about is not easy. If clinicians have been practicing in a certain way for so long, getting them to change is not the easiest thing to do. So I would suggest that the best way to get them to change is for you to come in with more information about your condition. I tell my family members the best thing you can be is an informed patient with your notepad about the things that have happened, and you get in front of them and you say, these are the things. And when they say, well, I've got to go, well, wait a minute, I've got 3 more things to address. Okay. Now, the other thing is every physician is now being measured by patient satisfaction. Of patient satisfaction, either by CMS, which is Medicare and Medicaid, or by private payers. So if you are not getting the satisfaction, you've got to know that you can escalate your problem through the patient contact or by writing letters. And folks, if you don't let other people know you're not satisfied, they're going to think that you are. Silence equals consent. And you can't be silent if you're not getting the care you need.
That's exactly right.
Dr. Jones, thank you so much. Before, I bring in the questions from our audience, I really just want to circle around, Tara, do you have any, we talked about, it really sounds like this is a multifaceted, but also multi-stakeholder solution-oriented problem that we have here, and really excited that all of us, you distinguished guys are from different kind of worlds, all contributing in different ways to make this possible. Before I move on to the audience, do you have any anything you want to add?
I want to add that if you have, or if anybody in your family or in your community has LDL-C and cannot figure out how to lower that, they've been working with their doctor, and this goes for high blood pressure, diabetes, and all of that, all ages, go see the specialist. Make sure you get those referrals in. We're struggling. There's a huge gap, and there's even a disparity issue in that a problem in that process, getting us referred to specialists. So please, 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 when you go in and you're geared for with your information, and the doctor says, they get offended because it's from Google. Use your Google, honey. If that's the best advice you can get right now, use that. So if that helps you understand, use that. If TikTok helps you understand, use that. And then when you go into the doctor's office and they have a problem with that, then you can simply say, well, it's because I don't understand what you're telling me. Yeah. And so just make sure, use your voice. It's the most powerful tool we have. Don't be afraid, because I had to get very combative with a cardiovascular doctor, my second heart attack, just to get an observation stay. These are within our rights. So just be mindful to use your voice. And they're just people in white coats, honey. And they bleed just like we do. And they grieve just like we do.
Tara, you're absolutely right. I tell my mother, who is 97 years old, who was having pain in her leg. And she said, well, the doctor said that was just, I said, nope, don't let anybody get away with just saying, well, you're older, you're 97. No, you have a pain in your leg. There's a diagnosis to that. Arthritis, bone cancer, whatever. Get the diagnosis. And then from there, you can request you want to see a specialist on it. And so again, it's our educating our own people to be advocates for their own health. It's a massive task that we have ahead of us, but it's not impossible if we're working together in our partnerships. And if we're demanding, again, the people who are making our healthcare systems and policies for those things, if we require and make demands on them to make those changes, I think we'll begin to see changes. And of course, educating our own people. So,
and Andrew, if I may add briefly, when you go to see your doctor, go in with a piece of paper with your notes of what you want to say, and leave with a piece of paper explaining what your doctor is talking to you about. You know what happens when patients leave our office? They'll go to talk to their trusted person in their community, in their family, or someone else. And if you have a handout that's addressing what your doctor talked to you about, it's a lot easier for you to get complementary understanding of what's going on. And if it's not accurate, then you've got a basis to escalate your problem. So don't count on your memory alone going in, because I can tell you that when someone hears something that doesn't sound right, the memory turns off, okay? And you can miss the next bit of information. So make sure you get patient education materials on all of the conditions that your doctor says they're treating you for. Okay?
No, so I'm excited because I think, not only are we talking about, the challenges or disparity in terms of policy, in terms of systems, but they're really focusing on very practical things we can start doing to really address some of these issues. And I'm here for that. I think that is fantastic. So we'll segue into questions from our audience. Please, if you have any questions, please put it in the Q&A chat box, and I'll read them out for you. So first, Dr. Jones, you ended this section. I'm going to start with you. And the question is, there's a lot of discussion about HDL and LDL. What about triglycerides as part of the lipid panel? Where do they come into the picture?
Actually, triglycerides, it's a critical part. Everything about the lipid profile is important, because each one of those things that you measure, the HDL, the LDL, the triglycerides, all of them play a role in what's called the viscosity of your blood, the thickness, the slugginess, and all. The things we're talking about, you can affect triglycerides much more readily by watching what you eat. Get away from the fried foods, eat more green leafy vegetables. But for some people, there are genetic bases to why their LDL or HDL may not work out. And so that's why we're talking about opportunities for medication interventions in those. But all of them are going to require doing a couple of things: eating more healthily, exercising. If you live in a 2-story house, walk up and down the stairs if it's too cold to go outside, okay? If you're a community activist, go to the big box stores and say, we want you to dedicate a portion of your parking lot as a safe place for people to come and walk, so we don't have to walk to communities that don't have sidewalks or communities that are dangerous. These are the ways that you can help to make a difference. So it's not all about prescriptions. It's about you're making major choices in your life and you're demanding changes in the environment in which you function. So I thank you for bringing up triglycerides. It is an important part of the cascade of managing cardiovascular disease.
Wonderful. So, Karen and Tara, I think I would love your input on this next question. The question is, and I believe this is from a nurse. I agree that shared decision-making is important. As a nurse, I've seen doctors talk with patients about treatment plans, and those patients aren't knowledgeable enough about the healthcare topics to really weigh in or even ask the right questions. How do we go about combating that?
Yeah.
What I would say is take someone with you. A lot of times, you know, especially when we talk about our older population, I think of my grandmother. I remember when she was about to go into surgery right before she lost her life, I was asking those questions. I might not have understood everything, but I wanted to know how does morphine affect her body at 85 years old if you put her under, you know, so we might not know all the questions we need to know to ask, but simply saying, I don't understand, or taking someone with you to say that for you. I don't understand what you're saying. How do we proceed forward? How do we get past this? How does the medication work with this medication? You know, all these conversations that need to be had. We have to maybe take someone with us, because I think a lot of times we get into the office and we just like the Ms. Jones said earlier, we just kind of get on mute, we get intimidated because, you know, if you think about Big Mom and all of them, they trusted their doctors to the T. It wasn't nothing you can say. You know, I even hear my moms now say, oh, my doctor didn't tell me to do that, you know, or my doctor didn't say that. So I think when we go in, maybe taking someone with us that's a little bit curious. We all got that person in our family that's just a little bit more curious about certain things and how they work, you know. So take that curious person in your family, that person with the loud mouth, that you know, that clown in our family. We all know who that person is. Take that person with us to the doctor's visit with us, so that they can advocate on our behalf and ask those questions when we're uncomfortable with asking them, because we don't know all the questions to ask.
Yeah, let me just say that I like doctors a lot, but I love nurses. And I know that when a doctor comes in and he explains something, this is the treatment, and then he leaves you with that nurse, the role that nurses play in really kind of breaking it down and then providing some of that intimate care and attention really helps. And of course, you want to ask all your questions of the doctor if you can, but anything you don't understand, don't miss that step of saying, can you explain to me what he meant on that? Because they can also help you. And it'll be a little bit more intimate probably in the thing. So I always like those nurses. We don't give nurses enough credit for what they do in our healthcare system. So kudos to the nurse that asked that.
And that's what I was emphasizing, team-based care.
Mhm.
Educational component of that care is often delivered by the nursing team, and that team, together with the clinician and the laboratory and the proceduralists, will help to get you what you need. So demand team-based care and demand shared decision making as a way of making sure that you know. And also, one last thing, there's something called CLAS, CLAS, culturally and linguistically appropriate services. Okay. That is something that is required. And if the practice that you attend does not use CLAS principles in treating you or your family members, then you got to call them to task on that. Okay.
Well, that is great. We have another question here. You know, I think the question is about, you know, we are talking about disease management, but what about prevention, right? You know, what do we have to say about disease prevention?
disease prevention is very, very important. But one of the problems you run into, we ran into before the Affordable Care Act came along, was that nobody wanted to pay for prevention. Okay, the payers, the insurance companies have you for that year, and they may not have you again. The employers have you while you're employed to pay for your care, but then they're afraid they'll lose you to someone else, so they don't want to pay for it. It wasn't until the Affordable Care Act came along that said that these are scientifically based prevention activities that should occur and should be paid for. And so that's increased our opportunity to get that. But prevention is a two-way street. When I sit here in my sometimes clean white coat and I say that we need to do these things to help you to prevent a problem, that doesn't mean you check out and don't go and try to do those things. Ask me a question about how to apply those guidelines, and I will work with you to develop a way to make sure that it occurs. But we've got to be able to make sure that we understand what prevention is, participate in it, and do the best we can to control our outcomes. One thing I've always been asked, I've got high blood pressure. Will I ever be able to get off the medicine? The answer is yes, unless you've got a very rare type. If you engage in the choice things by watching your weight and losing weight, exercising and watching your diet, you can reduce it enough that you may not need medication going forward. So keep that in mind, that you can play a big role in helping and making a difference in your life.
Yeah, Dr. Jones, thank you for sharing that. I think prevention plays a key role here. Karen and Tara, I have a question for you because you talked about step therapy. Karen, we wanted to know, so what other policy or practical solution would you implement to galvanize action around cardiovascular care for Black patients and halve the number of cardiovascular events by 2030?
So the other thing we do, other than really try to help improve our older adults who are within our network, again, and just being advocates for their health, we also ask them to be advocates in their community. It doesn't just start with trying to write a letter, which is important, writing to members of Congress, but also within your local health departments and working in those areas and getting, things done. So we're just really trying to get, look, we understand all of the things that impact us as a community, and it's not monolithic. One of the things we have to kind of get across to the wider world is everybody ain't poor, and everybody ain't unemployed, and everybody, because they lump us all together in one thing. But for those of us, we have been impacted, obviously, inequitably. And so and of course, it affects our health. And that's why we've had so many discussions on social determinants of health and how we can try to address those outside forces that have created such a health impact on why we have such poor quality of health and have to, move ahead. So one of the things that we're doing is we expand beyond just help the prevention part, which is really important and crucial on doing and taking our responsibility there. But we also work intergenerational. We don't want people to wait until they get to be 50 and decide that maybe I need to do this, because some of those conditions that you're trying to fight later on were probably set earlier just because of all the impact that we've had societal on us. Again, the unemployment, the racism, I'm not going to go through you all know all the social determinants. That's impactful on us, the stress of all of that. We want to really work on intergenerational. Let's start teaching our children now on ways that, one, they can help prevent the things that maybe later in life they won't have the same chronic diseases that their parents or grandparents had. Two, that they understand the importance of why they have to educate themselves and then move ahead. And then three, how important it is for them to be participants in the political realm, to understand the community, the things that we need to do to try to make changes within our own community. There are all sorts of things that we can do. But again, that's why partnerships and working together in our community to make these changes, I think that's how we can move this needle and see better results in the next, hopefully 20, 30 years, if not now.
Great. Tara, did you have something to add to that?
I agree. I believe that the work, like, not to toot Black Heart's horn or anything, but we've screened over 3,000 individuals, and that's age 12 and up. All that Ms. Jones just said happens on this bus. It's just not enough buses to go around currently. But I will say that meeting our people where they are is what's needed, from the local policies to the on up to Congress. We have to get back to meeting people where they are, making sure that we have. Earlier, before we got on, we talked about HBCUs potentially opening up more medical campuses, and we had 7 to start with back in the day, way before I was a thought. We had 7. Now we're down to 2. So we need more medical doctors in this space. We need more nurses. We need more culturally relevant medical information that pertains to us. Everything needs to be personalized, and that goes for any culture out there. And so I just believe that more of what Black Heart does is, we don't want to keep talking about it. We've been talking about it. It's time for solution-based activities to take place. And so I just think that as we get out into our communities and, the gardening, getting back to what we know as people that work for us, continue that trajectory, and we won't be where they say we will be in 2060.
Thank you so much, Tara. So what I would do is that we'll take our last question from the audience, and we'll wrap it up. And so this question is really interesting because the question is, this year is the 21st annual NMQF Leadership Summit and 23rd annual awards dinner. We started this conversation talking about how the rate of cardiovascular disease keeps on growing, even with more training, more education. Why do we think is a problem, even though there's more education, and although it's been a long time? Why do we think is a problem?
Dr. Jones, don't you think we've had a real setback as a result of COVID?
Yeah.
People didn't have access to actually seeing a doctor. I mean, the only way you got to the hospital is if you were really about to die almost. And that set a lot of our community back. And so maybe you're seeing a lot of it. And then, do we really understand how the disease, if you've gotten it, how it's affected you? I'm gonna let you do the medical part, but I know we've seen some things that really say that we've had some setbacks in the last 4 or 5 years.
We've had some setbacks, and people's physical health and mental health and emotional health have been challenged dramatically, and all 3 of those spheres interact. Okay. In addition to that, our systems have been challenged because a lot of clinicians left practice, okay, out of fear and out of other challenges. And a lot of them relocated to different areas. So we have huge areas. I have a family member who's fully insured that has to leave the county in which they live to go to another county to see a doctor that's covered on their plan. These are things that the business side of things that have impacted, and it impacts access to care. So we've got a lot we've got to deal with now, but it takes dialogues like these to make sure that we raise the issues that lead to meaningful policies. I got to tell you, when I was running Medicaid, when I would go on the radio or TV to talk about the program, they would always pair me with a politician. And I would have to tell them, I'm not here to talk politics. I'm here to talk policy. Talk politics. I talk policy. And my point to you is, if you look at what's happening in your community and you approach your elected officials and say, we're not asking you to get into a political battle, but these policies, there are data to support them, and you can help to make our lives better. I think that that's an approach that can make a big difference for you, especially for people who've had a decrease in their access to care. lack of coverage and increasing payments they have to make to get the same care they got before COVID.
And if I could add to that, I was on a call not too long ago, and they were saying COVID set us 10 years behind as far as cardiovascular disease is concerned across the board. But for minority communities, we know that that looks a little bit different, right? They're expecting to say that it set us 20 years behind from everybody else. And so for me, all of these problems already existed before COVID. It's just COVID shined a brighter light on these issues, and it forced others to see what was really going on in our communities and having to own that. So I do believe that we have been set back, but we know how to move forward because the solution, again, is within us. And I wanted to say something about prevention before we jump off of here. We have to remember that medicine might be a part of prevention for a lot of us. We cannot have it both ways. We cannot say, I don't want to take care of myself, but I don't want to take the medicine. So a lot of times someone will always be on medicine. And then also knowing how that medicine impacts your body, making sure you look at other alternatives outside of medicine, as such as yoga, grounding, breathing, meditation, all those things also play a part. And don't be afraid to ask for a dietitian to be a part of your team. We're missing out on that one piece. If we don't know how to eat for our bodies, and for your doctor to say, change how you eat, well, we might need somebody like a dietitian to help us navigate that journey as well. So make sure you have all the pieces to your puzzle, looking at everything on your plate, because everything flows through the heart. Nothing misses it.
This is wonderful, and as we come to a close, I really want to express our deepest, gratitude to Congresswoman Shafilah's McCormick for her leadership with the cardiovascular resolution that designated September as Cholesterol Awareness Month. I would also like to thank all of you, distinguished panelists, for being here. Today, you shared your insights. You shared your journey, you shared your expertise with us. We are inspired, we are empowered, and we know that from this conversation, we're going to make a lot of difference in our small community. So we talked a lot about different things today, from exploring practical and policy solutions to the present public health challenge. Each of you have provided invaluable perspectives that have enriched our understanding of cardiovascular health equity. And one thing that I want us all to remember as we log off is, for every 40 seconds, someone experienced a heart attack or stroke. Thank you very much.
Thank you.